Hello, this week we are back talking about stillbirth again, just as it's such a big and difficult topic. Last week we talked about risk factors and causes of stillbirth.
Yes, and this week we are going to talk about kind of what workup or investigations can be done in terms of trying to figure out why a stillbirth happened, and important things that patients who've experienced a stillbirth want to know going forward is there anything that we can do in terms of prevention, and then also some of the things to think about when you are planning another pregnancy after a stillbirth. If this is your first time meeting us, I'm Sarah. I'm a board-certified OBGYN.
I'm Kurt. I'm a board-certified pediatrician.
And we are the
Doctors
Doctors
Bjorkman.
As with last week's episode, we know it could be triggering for those of you that have had a pregnancy loss, stillbirth, or infant loss. It could also cause anxiety for some of you who are currently pregnant. So as always, please pause or skip this episode if you need to. It will be here when you are ready for it.
Yeah. We also know that after a stillbirth, you're going to have many questions about what happened, why did it happen, and what are the next steps to take.
Yes. As always, we want to provide you with evidence-based information so you can be informed.
Yeah. And with that, today we're going to cover the maternal and fetal workup, prevention of future stillbirth, and then also timing of a next pregnancy.
For all of the statistics and information on causes and risk factors for stillbirth, check out last week's episode. We know the risk of stillbirth is low in the United States at 0.6%, or 6 in 1,000 births after 20 weeks of gestation. But if you find yourself in that small group, you are looking for answers, and we hope we can provide you with some good information today. I briefly want to let you know what to expect if you find out that you have had a fetal demise while you are pregnant. I could do a whole episode about this, but wanted to at least share a few things from my experiences as an OBGYN taking care of patients that have had a stillbirth. First, patients are never prepared for the diagnosis of a stillbirth or fetal demise, and almost half of these late fetal deaths occur in otherwise uncomplicated pregnancies. This is devastating, heartbreaking, and a change your life moment and experience for patients. You go from having all this joy and excitement and hopes for a future child and your life, and that is taken away in a moment. Patients are often in shock and unsure of what to do. So studies have shown that parents of stillborns want good communication from their providers that is clear, respectful, and with time to listen and to talk. They want to find answers and be involved in the decision-making process. They want to be recognized as parents. I always try to use the baby's name, and most hospitals have things in place to help you create some memories with your baby, like footprints and handprints or taking photographs. I always encourage patients to meet their baby and spend time holding and loving them if that's something they want to do. These are some of the most heartbreakingly beautiful moments I have experienced in my career. It is a very challenging experience for everyone because you ultimately have to give birth to your baby that has died, and so that birth goes from you expecting it to be one of the best days of your life to one of the worst. And so just know that your OB team is there to walk with you through this grief. We have done it on more occasions than we wish, and it nearly breaks us every time as well. So things I encourage for my patients through the delivery process itself are pain control, family and spiritual support, and kind of just allowing patients to feel, react, and grieve in whatever way they need. It looks different for everyone, and there isn't a right or wrong way to feel or act or think. I always tell patients to ask all the questions they have, but if you don't have any, that's okay too. We will regroup when you are not in the midst of tragedy.
All of that, what happens after the birth?
Yeah. After the birth of a stillborn baby, there is some recommended testing to try to determine the cause of death. We want to run some lab tests as well as have a pathologist examine the placenta and fetal tissues under a microscope. Studies have not given us a single best strategy or guideline to follow. And even with a comprehensive examination, as we discussed last week, 25 to 60% of parents may be left without a definitive reason for their child's death.
Yeah, and so because there's no optimal evaluation for a stillbirth, the testing that's done is based on expert opinion. The American College of Obstetrics and Gynecology recommends that evaluation of a stillbirth should include fetal autopsy, gross and histologic examination of the placenta, umbilical cord, and membranes, and then also genetic evaluation.
Correct. So as we discussed last week, stillbirth is the end result of a variety of maternal, fetal, and placental disorders which can all interact to contribute to the fetal demise.
So after stillbirth, there are a lot of potential testing that your doctor may do.
Right.
One of the first things they start with is often a complete blood count, or CBC, as an abnormal result of this test could prompt further testing of things like hemoglobinopathies, blood disorders, or even problems like infection that could be the cause of fetal death.
Right.
They'll also often do a test that looks for fetal maternal hemorrhage, as we know that this could explain otherwise unexplained fetal demise. This is called the Kleihauer-Betke test or flow cytometry.
Yeah. Often a urine drug screen is ordered to look for cocaine use or methamphetamine use. Testing for syphilis in areas where it's very prevalent may be done, especially if it wasn't tested earlier in pregnancy. And then a fasting glucose or hemoglobin A1C might be done to look for glucose control, again, in patients who may not have had that checked earlier in pregnancy.
Yeah. Other things that they could test for would be a blood antibody screen. This could exclude something called alloimmunization. Also thinking about testing for antiphospholipid antibody testing, APLS, is a clotting disorder that can occasionally cause pregnancy loss.
Yeah. They will likely check a complete metabolic panel with liver enzyme function testing and possibly look at your thyroid function if there is clinical suspicion based on maternal symptoms.
Yeah. Now, there is some controversy over whether patients should be routinely screened for clotting disorders after a stillbirth. Expert opinion suggests possibly limiting this, and that if you're going to have testing for some of these clotting disorders, that it be done at least 3 months after pregnancy to make sure you're not catching some of the normal changes with pregnancy.
Right. Also, something we think about is testing for infection, but routine testing for infection is unlikely to be useful because many individuals may already be positive from having this infection sometime earlier in their life. So if clinically indicated, either by symptoms or ultrasound findings, sometimes your doctor will look for tests for CMV, toxoplasmosis, Parvo B19, or Listeria, depending on symptoms.
And finally, bacterial cultures should be obtained by the delivering clinician or the pathologist. Culturing the fetal skin or the placental surface, it can be misleading, and so that's where it's helpful to actually culture the internal fetal organs or the area between the amnion and the chorion, as these can be more reliable sources for bacterial culture.
Yeah. Experts also recommend an autopsy of the baby. This is because a complete clinical evaluation that we just talked about, plus this conventional autopsy with a placental exam as well, can diagnose the cause of death in the majority of cases. And this is important to most parents because they so desperately want to know, why did this happen and will this happen again? Answers to these questions are often impossible without information gained from doing this autopsy and pathologic exam.
Yeah. While all of this testing can seem very challenging and very invasive, the likelihood of finding a diagnosis depends really on how complete the examination is, the experience of the pathologist doing the examination of the autopsy and things, and then also how far along was pregnancy at the time of stillbirth. Some studies have shown that for cases receiving this optimal evaluation, the chances that a term stillbirth is unexplained after everything is down to only about 30 to 40%. One big question that comes up all the time is there any utility? Is it useful to do this autopsy? It seems really invasive to take your baby that you just lost and have someone examine them to try to find an answer, and I can imagine the heartbreak that goes with making that decision. Doing an autopsy will, however, find the result of death in about 50% or 1 in 2 cases. And this can do a lot to then help guide you and your family if you're thinking about having another pregnancy after, in terms of are there any things you can do to prevent future stillbirth, or was there anything else that you should know before going forward?
ACOG also recommends genetic testing of the baby to look for genetic causes. And so your team is going to talk to you about the different options and recommendations for the specific type of genetic testing that we would want to order.
Yeah. And again, the workup may reveal answers in terms of a cause of death that may allow your doctor to counsel you on the risk of another stillbirth, or things that may need to be changed to help prevent it in the future. There's some studies that have shown that the risk of stillbirth is higher in women who've had a previous stillbirth, meaning that your risk of having another stillbirth is 2.5% compared to the general population of 0.4 to 0.6%.
Rates of recurrent fetal loss are higher in women with medical complications such as diabetes, hypertension, or in those with obstetric problems with a significant recurrence risk, such as placental abruption.
So the question then becomes, is there anything you can do to prevent stillbirth, and what is your OBGYN going to do differently for your next pregnancy?
So kind of the most important thing is going to be correcting or optimizing any underlying medical conditions that may have contributed to the first stillbirth. After that, we kind of think about 3 other important things. And the first we call antenatal surveillance, or starting NSTs and fetal testing in the 3rd trimester. The second thing we think about doing is having patients do kick counts or keeping track of fetal movement. And then the third thing is talking with your OB and thinking about a scheduled early delivery.
Would you mind talking a little bit more about what antenatal testing is?
Sure. So for patients who have certain maternal or fetal medical conditions, often we start doing NSTs or non-stress tests, monitoring the baby's heart rate, and ultrasounds in the late 2nd or 3rd trimester. So this is done for things like twins or multiple gestations, growth-restricted fetuses, moms with diabetes or cholestasis or substance use, high blood pressure, or other complicating conditions.
Yeah. And again, because the risk of recurrent stillbirth is so much higher, actually 2 times at least more likely to have a stillbirth as compared to someone who's had a prior live birth, your OBGYN may likely recommend that you get antenatal testing with a future pregnancy.
Yes. So additionally, the risk of recurrent stillbirth may be even as high as 10 times more likely, depending on maternal race and characteristics of the previous stillbirth. And so for stillbirths that were associated with specific conditions like hypertension or diabetes, the fetal surveillance is absolutely recommended as part of management guidelines for those conditions.
For someone with a previous stillbirth at or after 32 weeks of gestation, the American College of Obstetrics and Gynecology recommends doing once or twice weekly surveillance, or that you start 1 to 2 weeks before the gestational age of the prior stillbirth. For stillbirths that happen before that 32-week mark of gestation, there should be an individualized conversation about when you should start that antenatal testing.
However, this approach of doing this testing early is associated with potential risk or morbidity and costs. So rates of delivery for abnormal or equivocal testing were 16.3% at or before 39 weeks of gestation and 1% before 36 weeks of gestation. And authors of another study estimate that antenatal testing before 37 weeks of gestation results in a 1.5% rate of early delivery for intervention based on false positive results.
Yeah. So it's interesting that the testing may give you some reassurance that you're going to try to catch something early, but there is a risk that you could have
an early delivery for no reason, and so it's something to talk through with your OBGYN.
The next thing we should discuss about prevention of future stillbirth is kick counts. And a great resource actually to check out is countthe.kicks.org.
Yes. So multiple studies have shown that women who report decreased fetal movement are at increased risk for adverse outcomes. Now, that being said, kick counting is an inexpensive test of fetal well-being, but evidence of its effectiveness in preventing stillbirth remains unclear.
Yes. So there's one study that has shown that if you provide uniform information to patients and their provider that they're about decreased fetal movement and how to manage that there's actually a decreased rate of stillbirth, which is great.
Yes.
However, there is another large randomized study that looked kind of at a similar process and didn't find this positive result, and did find that there were more early inductions and hospitalizations of pregnant women.
So because of this, there are insufficient data to make specific recommendations regarding fetal kick counts. Best practices regarding fetal kick counts and fetal movement seem to involve encouragement of awareness of fetal movement patterns, being attentive to the complaints of reduced fetal movements from patients and making sure that you feel heard by your provider, as well as making sure that providers are addressing these complaints in a systematic way, as well as using shared decision making between OB and patient when we are thinking about possibly employing intervention safely.
Yeah. And maybe this is a good time to talk about early delivery.
So this is a really important conversation to have with your OBGYN. The decision to proceed with an early delivery to prevent stillbirth has to weigh kind of the understanding of increased risks of maternal and neonatal complications compared with the potential benefits. Risks of pregnancy continuation are going to be different for each patient and largely dependent on underlying medical conditions and comorbidities of mom and baby in the current pregnancy. Deliveries before 39 weeks of gestation are associated with increased risk of admission to the NICU for respiratory complications and other neonatal comorbidities. However, you have to balance that with maternal anxiety in patients who've had a history of stillbirth and know that those should be considered and may warrant an early term delivery in kind of that 37 to 39 week window. And this, of course, is for patients who are well informed and they understand and kind of are accepting of the risks of that early delivery as well.
Yeah. So ultimately, care and delivery intervention should be based on the potential aspects of the mom and baby's conditions, as well as the risks and benefits associated with any suggested timing of delivery. When this suggested timing of delivery happens in that early term period, so 37 to 39 weeks, that timing should definitely balance the mom and baby risks of that early delivery with the risks of further continuing the pregnancy.
The last thing to think about is the timing of your next pregnancy. One of the questions I often get asked from patients is there an optimal time to wait to get pregnant again? And I always tell patients that the body may heal long before your heart and your mind do.
Yeah, but fortunately there are some studies to help guide you in this decision.
Yes. So a study published in The Lancet looked at the birth records of more than 14,000 women who had previously had a stillbirth, and this was in Western Australia, Finland, and Norway over the span of 37 years. A total of 2% of those subsequent pregnancies ended in stillbirth. 18% were preterm births, and 9% were babies born small for their age.
Yeah, this study notably found that those who conceived within 12 months of stillbirth, so having a baby, getting pregnant again in less than a year, were no more likely to have another stillbirth or a preterm birth than women who waited 2 or more years between pregnancies. Out of all the births in this study, more than 9,000 of them were actually conceived within 12 months of the previous stillbirth. As we talked about in our When to Have the Next Baby episode, one of the concerns about short interval pregnancy is not having enough time for your body to recover after a previous pregnancy, and then the risk of poor nutritional status, which has been linked to increased risk of fetal growth restriction and birth defects. However, this doesn't seem to be the case after stillbirth or miscarriage.
So with stillbirth, there aren't really any hard and fast rules. You want to talk to your doctor to make a plan for you. You want to think about your current health status, your current age, plus your goals for child spacing and ultimate family size. Most importantly, thinking about your emotional readiness to become pregnant again. Grief is not a straight line in terms of healing.
So we really hope that this episode has been helpful to you if you're someone who's recently suffered the loss of an infant or stillbirth. You have our hearts for sure.
Any questions or comments, please leave them below. Otherwise, we will see you guys next week.
We're doctors.
But not your doctors.
Anything we've said in this video is for education or entertainment purposes only.
It is not medical advice.
Any specific medical questions you have should be directed to your provider.